context.
Okay, I'm listening.
179 million.
Wow. That sounds like a national budget line item, doesn't it?
It really does, but we're not talking about dollars.
No, unfortunately not.
No. That is the number of acute gastroenteritis episodes that happen in the United States alone every single year.
It is a staggering statistic. I
Okay.
mean, if you do the math, that is essentially more than half the population of the country getting sick.
Right. So if you're sitting in a room with just one other person, statistically speaking, one of you is going to be, clutching your stomach and regretting that shrimp cocktail at some point in the next 12 months.
Right.
And we usually brush this off, don't we? We call it the stomach flu or food poisoning or just catching a bug.
It's treated as a bad weekend, a funny story about questionable airport sushi, maybe?
Exactly. Or a reason to binge watch TV while you're lying on the bathroom floor. But the stack of research you've brought to the table today, it paints a much darker, much more serious picture.
It really does. Because while most of us are lucky enough to bounce back after, 24, 48 hours of misery, the aggregate toll is massive.
How massive?
Out of those 179 million cases, we are looking at over 600,000 hospitalizations in the U.S. annually.
600,000.
And tragically, about 5,000 deaths.
And that's the crucial context we need to start with. That is happening here in a developed nation with clean water, with sanitation systems, advanced healthcare.
And when you zoom out from there to the global stage, the story changes from inconvenience to catastrophe.
Right.
Absolutely. If we look at underdeveloped and developing nations, acute gastroenteritis, specifically the kind involving severe diarrhea, is the leading cause of mortality in infants and children under 5.
A leading cause.
It isn't just a nuisance there. It is the #1 killer.
Ooh. That really reframes the whole mission for this deep dive then. We aren't just talking about how to handle a tummy ache or what to eat when you feel gross.
No, not at all.
We're looking at a global health crisis and the biological mechanics behind it. So our goal today is to sort of demystify this biological battle happening in the gut.
Yeah, let's break it down.
We're going to look at the etiology, which is, just the medical term for the cause. We're going to break down the actual physics of dehydration, distinguish between all the different bacterial invaders, and finally talk about the vacation ruiner, traveler's diarrhea.
And I think along the way, we're going to dismantle some very persistent myths. Because a lot of what your grandmother told you to do when you're sick, and honestly what a lot of us still do, is actually scientifically wrong.
I love busting grandmother myths.
Yeah.
So let's unpack this. We're starting with what you call the absolute cornerstone of survival. When this hits you, whether it's a virus, a bacteria, a parasite, your body enters crisis mode.
It does.
And the source material is crystal clear that there is one thing and one thing only that determines whether you stay home or you end up in the ER.
Rehydration. It's the single most critical factor.
It sounds so basic, to drink fluids. But digging into this data, it's actually it's a complex chemical balancing act. It's not just about wetness.
Not at all. And here is the bottom line. It doesn't matter if you have a rotavirus, salmonella, E. coli, or a parasite you picked up swimming in a lake. The primary treatment goal is identical.
Let's get water back in.
You have to replace what you are losing. Because generally speaking, the bug itself doesn't kill you. The fluid loss kills you.
Okay, so let's talk about that danger zone. Because everyone feels thirsty when they're sick. I mean, dry mouth is pretty standard. But how do you, as a parent or a caregiver, distinguish between I'm thirsty and I'm in medical danger?
That's the key question. How do we assess dehydration properly?
Yeah.
The clinical literature points to one absolute gold standard for assessing it, but it's one that almost nobody uses at home, which is a bit of a problem.
Which is what?
Weight loss.
Weight loss. You mean literally stepping on a scale while you're sick?
Strictly speaking, yes. If you want to know exactly how dehydrated a child or an adult is, you compare their current weight to their baseline healthy weight. Water is heavy. So if a 20-pound toddler suddenly weighs 18 pounds after a day of sickness, that 10% drop isn't fat burning. It's water volume. And that represents severe, potentially life-threatening dehydration.
That makes total sense scientifically, but
yeah,
practically speaking, if I'm lying on the bathroom floor at 3 in the morning or my kid is screaming, I'm probably not going to be calibrating the bathroom scale.
Exactly. That's the problem. It's the most reliable metric, but it's the hardest to get in the heat of the moment. So we have to rely on clinical signs. You have to be a bit of a detective here.
Okay, so what am I looking for? Walk us through them.
First, look at the face, specifically the eyes. Are they sunken? Yeah. When we lose fluid, the little fatty pads around the eyes lose volume. and the eyes literally sink back into the orbits. Next, check the mucous membranes. So look inside the mouth. Is it moist and pink, or is it dry and sticky? Tacky, even.
And there's a specific note here about crying that I found really interesting, actually.
Yes. Decreased tearing. This is a big one. If a child is crying, and they usually are if they're sick and miserable, but there were no tears running down their face, that is a major red flag.
Why?
The body is conserving moisture to keep the vital organs running. It simply cannot spare the water for tears.
Wow. That's chilling. It's like the body is shutting down non-essential services.
That's a good way to put it.
There's also a physical test mentioned called skin turgor. Can you explain how to do that correctly? Because I feel like I'd just be pinching someone for no reason if I didn't know the technique.
Right. It's a recoil test, basically. You're testing the elasticity of the skin. You gently pinch a fold of skin, usually on the abdomen or the back of the hand, and pull it up a little bit. In a fully hydrated person, the moment you let go, it snaps back flat, instantaneously.
Like a rubber band.
Exactly like a rubber band. But if you're dehydrated, the skin loses that turgor, that elasticity. If it tense, meaning it kind of stays up or takes a second or two to slide back down, that's mild to moderate dehydration.
And severe.
If it takes longer than 2 seconds to return to normal, you are dealing with severe dehydration. Time to get help.
And you'd combine that with, what, their mental state?
Correct. You're looking for apathy or lethargy. And this sounds weird, but if the person is irritable, screaming, and grumpy, that's actually better than if they were just staring at the wall.
Really?
Yes. If they're too tired to drink or they just don't care anymore, that is an emergency. That altered mental status means the brain isn't getting what it needs. You need an IV at that point.
Okay, so let's say we've caught it before that point. We've spotted the signs. We need to get fluid back in. And this is where I think 90% of people, myself included, historically get it wrong. My first instinct is to grab a ginger ale, maybe a flat ginger ale or a spurts drink, the blue stuff.
And the data says, put the blue stuff down and definitely put the soda down.
But why? It's got electrolytes. It's liquid.
It has electrolytes, sure, and it is wet, but it has the wrong balance. This is where we need to get into the chemistry a little bit.
Yeah.
There's a table in the source material, table 39-2, that compares the composition of common drinks against what the body actually needs.
Then the key word here is osmolality. Can we break that down? Because that sounds like high school chemistry trauma, but it seems vital.
It is high school chemistry, but it's the difference between getting better and getting worse. So osmolality basically refers to the concentration of particles, sugar, salt, stuff like that, in a liquid.
Okay.
Your body's cells have a specific osmolality. If you drink something with too high an osmolality, like a cola or apple juice, which are packed with sugar, it is what we call hypertonic.
Hypertonic, so more concentrated than my blood.
Right. And here is where physics bites you. Osmosis tries to balance things out. It wants the concentration to be the same on both sides of the intestinal wall.
Okay.
So if you dump a sugary, hypertonic liquid like soda into your gut, your body says, whoa, that's way too concentrated. And instead of absorbing the liquid into the body, your body pulls water out of your bloodstream and dumps it into your gut to dilute the sugar.
Wait, hold on. So I drink the soda to hydrate, and my body actually pushes water out of my cells into my stomach.
Exactly. You are literally drawing water from your own cells to handle the soda.
Yeah.
This increases the volume of fluid in the bowel, which makes diarrhea worse.
You're flushing your own hydration down
the toilet. You are.
That is wild. It's completely counterintuitive. I think most people assume liquid equals hydration.
It's a dangerous assumption.
Yeah.
And chicken broth has the opposite problem. Often too much sodium, not enough sugar to help absorb it. Sports drinks are usually way too much sugar and not enough sodium to replace what you've lost.
So what is the gold standard? What should we be drinking?
It's an oral rehydration solution, or ORS. You know the names. Pedialyte, Inflyte, or the WHO and UNICEF packets you mix with water.
And these are different because?
They aren't just drinks. They are engineered liquids. They use a specific biological trick called the sodium-glucose cotransport mechanism.
That's a mouthful. Let's unpack that mechanism. What does that mean?
Okay, so think of the lining of your gut as a wall with a bunch of doors. When the gut is inflamed or sick, many of those doors are locked or broken.
Right.
But there is one specific door, the sodium-glucose door, that usually stays open, even during severe illness. But it works on a buddy system.
A buddy system.
Yes. Sodium can't get in without glucose, and glucose can't get in without sodium. They have to hold hands to cross the border, so to speak.
I see.
If you just drink salt water, it doesn't work. If you just drink sugar water, it doesn't work. But if you have them in the exact right ratio, which is what ORS is, they pair up, walk through the door, and water follows them both in.
So ORS provides the perfect ratio of buddies to sneak the water past the guards.
That's a great way to put it. One sugar molecule, one sodium molecule, and water rides their coattails. It maximizes absorption even when the gut is damaged.
Okay, so we have the right fluid. Now, how do we drink it? Because the source has a very specific instruction here that sounds, well, honestly, incredibly tedious.
It is the sip, don't chug rule. And yes, it requires a lot of patience. Imagine a child who is vomiting. Their stomach is very irritated.
Right.
If you let them chug a whole glass of Pedialyte just because they're thirsty, the stomach wall stretches rapidly. This triggers the vagus nerve, and boom, it comes right back up.
Defeating the purpose entirely.
Completely. The recommendation in the text is 5 milliliters. That is a single teaspoon every 2 to 3 minutes.
A teaspoon every 2 minutes. That means it would take, what, over an hour to drink a regular cup?
Roughly, yes. It's slow. But by doing it in teaspoon increments, the fluid trickles down the esophagus, slides past the stomach, and gets into the intestines before the stomach even really realizes it's there.
You're bypassing the vomit reflex.
You are. It's tedious, and the kid might get annoyed, but it is the difference between staying home and an ER visit for an IV.
That is a huge takeaway. Teaspoons save trips to the hospital. Okay, let's pivot to food. Growing up, the rule was starve a fever, or at least rest the gut. Don't eat anything for 24 hours. Let the system clear out.
That is a very, very pervasive myth, and the source material completely flips it on its head. It explicitly states that early initiation of feeding actually shortens the course of diarrhea.
Eating makes you get better faster.
Yes, your gut lining, the mucosa, needs fuel to repair itself. Those cells turn over very quickly. If you starve the body, you're depriving the construction crew of bricks. You want to resume an age-appropriate diet as soon as rehydration is achieved.
But we aren't talking about a double bacon cheeseburger here, I assume.
Definitely not. You want the classic brat diet vibes, so bananas, rice, applesauce, toast or complex carbohydrates like cereals, lean meats, yogurts, fruits, and veggies.
And what are we avoiding? What are the villains of the menu?
The 3 highs: high fiber, high sodium, and high sugar.
Why those 3?
High fiber makes the gut work too hard mechanically. It stimulates motility, which you don't want right now. High sugar causes that osmotic problem we just talked about. And fatty foods delay stomach emptying, which can make you feel nauseous again.
Got it. So feed the gut, but be gentle. Don't make it run a marathon while it's recovering.
Precisely.
Okay, so we've covered the survival kit, fluids, and food. Now I want to meet the enemy. We've got a cast of characters in these documents that range from, annoying to downright deadly. Let's start with the bacteria.
The heavy hitters.
And the king of the heavy hitters has to be cholera. I feel like in the modern West, we think of cholera as something from a Dickens novel or a history book about 19th century London. But biologically, this thing is a monster.
It is the extreme example of what we call secretory diarrhea. It's caused by the bacterium Vibrio cholerae O1, and the way it works is just fascinatingly destructive.
How so?
It doesn't just damage the gut, it hijacks it.
Walk us through the mechanism. Bacteria gets in, then what?
It releases a specific protein called an enterotoxin. This toxin latches onto the cells lining your small intestine and essentially hacks the cellular control panel. It flips a switch that increases a molecule called cyclic AMP.
And what does cyclic AMP do? Why is that bad?
Cyclic AMP is a messenger. And in this case, it tells the cells to open the floodgates. The cells start actively pumping chloride ions, that salt, out of the cell and into the hollow space of the gut, the lumen.
And water follows salt.
Water always follows salt, so it reverses the flow. Instead of absorbing water, your gut becomes a high-pressure water pump.
A very high-pressure pump.
An incredibly high-pressure pump. It creates an isotonic secretion that completely overwhelms the colon's ability to reabsorb fluid. The volume of loss is just staggering. The text mentions a patient can lose up to 1 liter of fluid per hour.
1 liter per hour. That's a large Nalgene bottle every 60 minutes.
Leaving your body, you'll literally see the patient deflating. The skin loses all tension. The eyes sink in. The blood actually thickens because the water is gone. The source notes that without rapid treatment, death can occur in as little as 2 to 4 hours.
That is terrifyingly fast.
It is. And the stool isn't even stool anymore. In medical texts, they call it rice water stool. But it's basically just blood plasma minus the proteins. You're flushing your life force out.
So how do you stop it?
Speed is everything. You need massive rehydration, often IVs if it's that severe. And interestingly, Cholera is one of the few times where antibiotics are definitively recommended. A single dose of doxycycline is the preferred treatment.
Why antibiotics here? I thought we were supposed to be saving those.
In this specific case, the antibiotic kills the bacteria that's producing the toxin. It significantly shortens the duration of the diarrhea and the volume of fluid loss.
I see.
And in a situation where you are losing a liter an hour, cutting the illness short by 12 or 24 hours is the difference between life and death.
Okay, so cholera is the nightmare of watery diarrhea. But there's another category in the notes that sounds even more unpleasant. Dysentery.
Yes. And for you listening, this distinction is critical. If you take one thing away from the pathology, let it be this. There is watery diarrhea, which is about volume depletion, and then there is dysentery, which is about tissue damage.
And how do we tell the difference?
Dysentery is often bloody. It implies that the pathogen hasn't just sat on top of the cells and pumped out water. It has invaded the intestinal wall. It's burrowed in.
That is a horrific image.
It's an invasion, and this causes inflammation, destruction of the mucosal cells, and bleeding. We're talking about bugs like Shigella, Salmonella, Campylobacter, and the very dangerous enterohemorrhagic E. coli, or EHEC.
And this distinction matters for treatment, right? Because I feel like there is a huge debate about antibiotics. People want a pill to fix it, but doctors are often hesitant.
That is the antibiotic debate, and the source material is very firm on this. For most mild bacterial diarrheas, antibiotics are not essential.
Not essential.
In fact, if you just take antibiotics blindly, what we call empirical therapy, you might do more harm than good.
Because of resistance.
Resistance, side effects, and cost. For a start, most of these infections are self-limiting, meaning your body will clear them in a few days on its own.
But there are exceptions.
There are. If you test positive for Shigella, you use ciprofloxacin or azithromycin. If it's Campylobacter, azithromycin is the go-to.
So the takeaway is, don't demand antibiotics unless you know what you're fighting.
Yeah, exactly. Get a diagnosis first. Don't throw a hand grenade into your gut unless you know the enemy is actually there.
Speaking of not knowing what you're fighting, let's talk about a scenario where you usually can't get to a lab. You're on your honeymoon in a tropical paradise. Or you're backpacking through Europe, and suddenly, disaster.
Traveler's diarrhea, the classic vacation ruiner.
What is actually happening here? Is it just different water? Is it the spices?
It's usually contamination. Traveler's diarrhea isn't a specific disease. It's a clinical syndrome caused by ingesting fecal contamination in food or water. And the usual suspects are bacteria your body just hasn't met before. Enterotoxigenic E. coli, or ETEC, accounts for anywhere from 20 to 72% of these cases.
So it's an E. coli that the locals might be immune to because they're exposed to it constantly, but your immune system sees it and just hits the panic button.
Precisely. It's a stranger to your immune system, and your immune system freaks out.
Now, I might be people who pack antibiotics just in case, or even take them beforehand to prevent getting sick. What does the data say about that?
That's called prophylaxis.
Well, yeah.
And the stance in our source material is generally, no, do not do it.
Why not? Isn't it better to be safe than sorry?
It's all about the risk-benefit analysis. Antibiotics have side effects, rashes, photosensitivity, and as we will discuss in a minute, catastrophic gut damage. The recommendation is to avoid prophylaxis unless you are a high-risk individual.
Okay.
Or you're on a short-term mission where illness would ruin the purpose.
Like if you're a Navy SEAL on a raid.
Exactly. Or a diplomat at a 48-hour peace summit where you absolutely cannot leave the room. If you were just sitting on a beach in Cancun for a week, the risk of the side effects outweighs the benefit of avoiding a couple of days of diarrhea.
So if we don't prevent it, we have to treat it. And this brings us to the drug that is in every travel kit I've ever seen, Imodium, loperamide. I call it the plug drug.
A vivid but accurate description. Loperamide is an antimotility agent. It effectively paralyzes the muscles of the gut to slow transit time.
It's a lifesaver on a plane or a long bus ride.
It can be. It offers symptomatic relief. It stops the urgency. But, and this is a massive flashing red neon but UT that everyone listening needs to hear, there's a critical warning in the text.
I saw this. It's contraindicated in certain cases.
You must never, ever use loperamide if you have bloody diarrhea or a high fever.
Okay, I want to pause on that. If there is blood or if there's a fever, do not use the plug. Why?
Okay, imagine you have an intruder in your house, a toxic intruder who is smashing the windows. Your body is trying to push that intruder out the back door as fast as possible. That's the diarrhea.
Okay.
If you take a loperamide, you are locking the doors and trapping the intruder inside with you.
That is not good.
Not good at all. If you have a toxin-mediated disease like Shigella or EHEC, Stopping the gut movement traps the toxin against the intestinal wall. It increases the contact time. This can lead to severe damage, systemic toxicity, and it prolongs the illness.
So the rule is, if it's just watery and you feel okay otherwise, Imodium is okay to get you through the flight.
Yes.
But if you feel feverish or see blood, let it flow.
Blunt, but correct. And even for safe usage, watch the dosing. The source specifies 4 milligrams initially, then 2 milligrams after each loose stool, max 16 milligrams a day. And if you aren't better in 48 hours, stop taking it. It's not working and you need a doctor.
Okay, we need to talk about the antibiotic paradox. We mentioned side effects earlier. But there is a specific nightmarish condition that is actually caused by treating an infection.
We need to talk about Clostridium difficile, or C. diff.
This is the one that hospitals are terrified of.
Correct. C. diff is the most common cause of infectious diarrhea in hospitalized patients in North America and Europe. And the irony is cruel. It is an opportunistic infection that only thrives because you took antibiotics for something else.
Explain the forest fire analogy here. How does medicine cause a disease?
Okay, think of your gut microbiome as a dense, healthy forest. The trees are your good bacteria. They take up all the sunlight and soil nutrients, so weeds can't really grow.
Got it.
But then you get an infection, maybe a sinus infection, and you take a broad-spectrum antibiotic. The source lists drugs like clindamycin, ampicillin, cephalosporins, fluoroquinolones.
These are the napalm?
Right. They burn down the forest. They kill the bad bug in your sinus, but they kill the good trees in your gut, too. Now you have an open field of ash.
And in comes the weed?
Exactly. And C. diff is a weed that is resistant to that fire. It sees the empty space, sees no competition, and it just takes over.
And it's not just a little upset stomach.
No. It produces toxins that attack the lining of the colon. It can range from watery diarrhea to a life-threatening condition called pseudomembranous enterocolitis or toxic megacolon.
Toxic megacolon. That sounds like a heavy metal band, but I assume it's a medical emergency.
It is. It means the colon becomes massively distended, inflamed, and can actually perforate. It can burst. It has a high mortality rate.
So how do you treat the infection that was caused by the treatment? It seems impossible.
Step 1. Stop the offending antibiotic immediately. Stop pouring gas on the fire.
And then?
Then you have to use very specific antibiotics that target C. diff. Metronidazole is the first line for mild to moderate cases. For severe disease, we use oral vancomycin.
It just feels like an arms race.
It is. And the frustrating part is the relapse rate. About 20% of patients will clear the infection, and then boom, it comes back a few weeks later. The spores hide out and then reemerge.
And this leads us to a treatment that has been getting a lot of press lately. It sounds gross, but the science is undeniable.
Fecal transplantation.
It is exactly what it sounds like.
It is. You take stool from a healthy donor, someone with a lush, healthy forest of bacteria, and you transplant it into the patient's colon.
You are reseeding the forest.
Exactly. And for patients with recurrent C. diff who have failed antibiotic treatments, this can be a miraculous cure. It restores the ecosystem that keeps the C. diff in check.
It's amazing science. High ick factor, but very high reward. And just to reiterate, you never use Imodium for C. diff, right?
Never. That significantly increases the risk of toxic megacolon. You absolutely do not want to trap C. diff toxins inside you.
Okay, we've done the bacteria, we've done the hospital superbugs. Let's talk about the ones that probably hit our listeners the most often at home, the viruses.
Viruses are actually the leading cause of diarrhea globally.
And the two main characters here are rotavirus and norovirus.
Right. Let's start with rotavirus. Historically, this has been the scourge of childhood. It is the most common cause of severe diarrhea in infants and children worldwide.
And it accounts for a huge portion of those mortality statistics we discussed at the start.
A huge portion. Around 1 million deaths annually, globally.
But there is some rare good news here.
Huge news. We have effective vaccines.
Yeah.
In the U.S., routine rotavirus vaccination is recommended for all infants beginning at age 2 months. You have vaccines like Rotatec and Rotarix.
And this has changed the game.
Drastically. We've seen a massive drop in pediatric hospitalizations for dehydration. It is a major public health victory.
Then there's norovirus. The winter vomiting bug, the cruise ship bug.
Ah, yes. This one is a menace because it affects all age groups and it is unbelievably contagious.
Why is it so good at spreading?
It's durable, and it spreads via aerosolized particles. When someone vomits, well, microscopic particles float. If you breathe them in or they land on a surface you touch, you're infected.
And you only need a tiny viral load to get sick.
A very tiny load.
And antibiotics.
Useless. It's a virus, and antibiotics kill bacteria. They do absolutely nothing here except destroy your microbiome and maybe give you C. diff down the line.
So we are back to square one.
Back to supportive care.
Yeah.
Rehydration.
Right.
Waiting it out. It really does come full circle. So we've covered a massive amount of ground here, from the physics of a teaspoon of water to the biology of a forest fire in your gut. Let's try to synthesize this. If our listener takes away 3 things from this deep dive, what should they be?
If I had to boil it down, number 1, fluid replacement is the cornerstone. If you don't get the fluids right, nothing else matters. Learn the signs of dehydration, weight loss, lack of tears, skin turgor, and master the art of the teaspoon sip. Use an ORS, not a soda.
Okay.
And number 2,
know your diarrhea types. Watery versus bloody. This distinction is the traffic light for using drugs like Imodium. If there's blood or fever, the light is red. Do not use anti-motility drugs.
And the antibiotic lesson.
That antibiotics are a double-edged sword. They are life-saving for cholera or severe traveler's diarrhea, but they are the trigger for the nightmare of C. diff. Do not use them casually. Do not use them just in case.
That is a really solid summary. But before we go, I want to touch on one last thing. I feel like everywhere I look, people are pushing probiotics. Take this yogurt, take this pill, it'll fix your gut. What does our source actually say?
This is where it gets really nuanced. The source acknowledges that several systematic reviews show probiotics can reduce the duration of diarrhea by approximately 17 to 30 hours.
Which sounds great. Getting better a day early, I would pay for that.
Right, who wouldn't? But then comes the scientific brake pump. The text states there is still insufficient evidence to officially warrant a recommendation for traveler's diarrhea.
Why the hesitation?
Because probiotic is a vague term. It's like saying plants. Some plants are lettuce, some are poison ivy. We know something is happening, but the data doesn't clearly define which specific strain at what specific dose works for which specific illness.
So we're left in this weird limbo.
Exactly, and that raises a provocative question for you, the listener, to take away.
Yeah.
We live in this gap between promising data, saving 30 hours of sickness, and official recommendation.
In that gap, how do you make decisions for your own health? Do you wait for the perfect study? Or do you take a chance on the yogurt because the risk is low and the reward is a day of freedom?
That is something to chew on. Hopefully not while you have the stomach flu.
Hopefully not. That's it for this deep dive into gastrointestinal infections. Stay hydrated, everyone!
And wash your hands.
See you next time.